Good morning. I'm Oliver O'Connor, Chief Executive of the Irish Pharmaceutical Healthcare Association. Welcome along this morning to our Digital Think-In series, which is our replacement for our live and person-to-person conference, which we've always run in the association over the last 25 years. So the Digital Think-In series is the replacement of the best of a conference, that is thought leadership, provocative insights, and sharing of those afterwards if people wish, on themes and topics which are relevant to our work and where we can bring some developmental thinking into our organizations. We are very happy to have Uniphar sponsoring this Digital Thinking series, as they have our conference over the last number of years, and we thank them for that. This morning, we are having a presentation and a discussion on a much broader theme than we would normally have dealt with. This is on the social determinants of health, led and provided by PwC. PwC have been partners with IFA, Irish Pharmaceutical Healthcare Association, over many years in our conferences and in our major set piece event, Biopharma Ambition. The presentations, I'm sure you will find very thought-provoking. They are for all of us to consider, whether we're in services to our industry, members of a pharmaceutical company, whether we're in public policy, whether we're providing communications or legal services or otherwise. You will find this presentation very thought-provoking, stimulating, and hopefully there will be specific operational matters that you can pursue in your business resulting from them. So this morning, I'm going to hand over in a minute to the PwC team, who will be joined by Liam Cullen of GSK, formerly of this parish, who will be providing an industry insight in the panel discussion afterwards. The discussion will be led by our very good friend Jean Delaney, a partner in the PwC practice in Dublin. It will have also from Dublin Shane Gannon on it. And then the main presentation will come from Nancy Park and Moise Hamid of PwC in the UK. So with that, I'll hand over, and I look forward to saying hello and goodbye to you at the end of the presentation as well.
Good morning, everyone. Just before we get started into the presentation, which Moise and I will take you through, we've got a poll. We've got 3 questions in the poll on the right-hand side of your screen. So just to get our brains moving early in the morning, we've got 3 questions there. When you get a chance, if you could go into it and then click on which you think are the right answers. So the first question is, what percentage of the person's health is clinical care attributed to, 20, 60 or 80%. The second question is, in the PwC 2019 HRI survey, which of the following was cited by respondents as being the most important in preventing the adoption of the healthy lifestyle? And the third question is, have you downloaded the COVID Tracker app? We have quite a number of participants today, so we won't go through the answers immediately, but we'll leave them there for you to have a think. The first 2 answers are within the presentation, and we'll share the results at the end. So the social determinants of health. What we wanted to do today is take you through some of the key points following a study undertaken by PwC's Health Research Institute, where we looked at the social determinants of health. Now, whilst this isn't a new concept, what we did want to do is put a spotlight on something that has global relevance, and with health inequalities widening, further action must be taken. We convened a global advisory group of PwC healthcare leads from across different territories, and we explored issues around the social determinants of health. And what we found was, regardless of the way governments are structured or the form of provision between the public and private sectors, the issues and challenges of tackling health inequalities and redressing the social determinants of health remain the same. And the challenges of COVID we're facing at the moment only exacerbates the harsh realities of those health inequalities that persist in society. And through the study, we identified 5 key components and action points to address the social determinants, which we would like to cover through this presentation, along with some example case studies. The PwC research is based on interviews with health industry executives, community organisation and government-funded health and social programmes, a consumer survey of roughly 8,000 people, participants across different countries in the world, and also desktop research. The study clearly highlights the case for social determinants of health and why it's so important and why we need to take action now. And we know there's a key question: if the world is getting wealthier, why isn't it getting healthier? According to the World Bank, about 1.1 billion fewer people are living in extreme poverty than that was 30 years ago. And between 1990 and 2010, health spending by OECD countries nearly doubled. And yet people are getting sicker across the world. Shane, if we could move on to the next couple of slides, that'd be helpful. We can see that rates of chronic disease such as cancer, diabetes and cardiovascular disease rose consistently from 2000 through to 2016. And between 2014 and 17, there's been more than a 10% increase in the share of population in OECD countries deemed overweight or obese. And we know that these conditions obesity makes people more prone to a range of chronic health problems that we've just mentioned. This study team also compared data from Japan and the US, which shows how behaviours and environmental factors may have more of an impact than the money you spend on healthcare and healthcare services. So here we can see in 2016, the US spent 17% of GDP on healthcare, while Japan spent just under 11% for its population, which includes a significantly higher proportion of those 65 and over as compared to the US. But in the US, 65% of Americans are overweight as compared to only a quarter in Japan. We also see in the US per capita sugar consumption is almost twice as what it is in Japan. So there are examples of public health interventions that can help, like the sugar tax in Mexico has seen a reduction in sugar consumption. There's also, interestingly, a requirement in Japan whereby the Japanese are required to submit their weight on an annual basis, a bit like a census submission. But on the whole, despite these major investments and interventions initiatives, countries have not seen material shifts towards healthier habits that could prevent chronic conditions. So we see here examples of what between 1990 and 2010 in the OECD, for example, smoking rates dropped 31%, but alcohol use only fell 8%, and the rate of daily vegetable consumption increased by just 2%. Some of this clearly sits within self-health management, and 43% of respondents to the PwC survey said that they admit that they bear the greatest responsibility for addressing the behavioural and socio-economic factors contributing to their own health. But that doesn't necessarily mean that they're doing anything about it or even know how to do something about that. And this limited progress is cause for concern because clinical care, while vital, is responsible for only 20% of the person's health. So even the most advanced medical interventions are ineffective when people struggle with social isolation, income inequality, poor nutrition and pollution. Health systems often remain focused on creating solutions after people are already sick and in crisis rather than prevention. And that's quite often driven by funding mechanisms or funding constraints or political priorities at that particular point. So social determinants all affect how people experience the world and the choices that they make. And in the global survey, we see that 1 in 5 respondents indicated that they couldn't afford a healthy lifestyle, and a similar share shared that they did not have time to focus on healthy behaviours. So we know from all of the results and the data, the evidence that we're seeing, that the social determinants are playing a key part. We know that education literacy is a primary factor, which also correlates to other determinants such as jobs and diet, hunger and diet. We just talked about obesity, known to further cause chronic health conditions. This is then also linked to transport, environment and safety with pollution, transport and infrastructure being very important to create the encouragement of that active, healthy lifestyle, such as cycle lanes and park and ride facilities, reducing admissions, as well as encouraging more physical activity and housing, and so on. So all these points and the social determinants are very much linked in all of this. Improving our collective mind state might be a key, as shown in the global survey. In a screen-filled technological world that we live in at the moment, especially now during lockdown, many of us are remote working and in our homes a lot more than we were before. The state of our minds might be the key to unlocking better health. And survey respondents said that they're not getting enough sleep, distracted by phones, lack of motivation, and struggling with mental health issues such as depression and anxiety, all of which doesn't set the right frame of mind for healthy decision making. And also a host of social factors can feed into the lack of sleep, working multiple jobs, caring responsibilities, lacking proper social housing, or suffering from stress. So all of these play a key factor in keeping people well, or overcoming those things to keep people well. But the good news is that it can be done. All these points can be addressed. Moyes will now take us through some of the 5 steps for the bold actions that we all need to be thinking about and taking part in, and sharing some examples as well.
Thank you, Nancy. So how do we lead in terms of delivering on the 5 key steps for the social determinants of health? So the five key steps include building a collective will, where there's ownership and responsibility and clear lines and delineation, and where true costs can be understood. To develop standard and adaptable frameworks, where common frameworks, clear obstacles, and fast track efforts to work together. To generate insights from data and to inform key decisions. So data and analytics are important and can guide plans by finding targets and predicting impacts, as well as demonstrating return on investment. Engaging and reflecting within the community is also a key. And social determinants of health programs should be grounded in the reality of how people live and work. And the final step is measuring and redeploying. So really reflecting on how programs have been delivered. And partners should use evidence to fine tune and grow social determinants of health efforts, and to keep other partners accountable. Shane, if we could move on to the next slide. So how can we build the collective will? It requires a recognition that we can't solve the problem alone, and that everybody has something at stake. Expanding the dialogue beyond the physician is important. In our survey, we found that 1/3 of consumers said they hadn't engaged in conversation with any stakeholders about social determinants of health. And of those that we did have conversations with, very few were with stakeholders other than physicians. So it's important that the dialogue is expanded beyond the traditional physician-doctor led treatment. And also to assemble coalition and align goals, and to win community buy-in and build sustainable support. So it's important that leaders find ways to show prospective partners how their goals align meaningfully, and to look beyond traditional partners, for example, to community groups, government, universities, etc. And also to develop evidence-based public campaigns to win sustained community buy-in and support. And to avoid the hesitation of upfront investment. So sharing risk and aligning public and private budgets is also very important. Shane, could we go on to the next slide? Addressing the social determinants of health requires collaboration within and across sectors. So it's important that the governments, providers, payers, and the pharma life sciences industries are all key stakeholders within healthcare. Are involved in successful collaboration with employees, research and policy groups, and tech and communication firms, to ensure that complementary capabilities and skill sets and resources are aligned, and that there's similar motivations to solve the problems at hand. And a good example that we've come across is the digital health startup Healthify. Sorry, could I just go back to the previous slide? Who recently announced a collaboration with Landmark Health to help connect their complex chronic patient and medical behavioural, social and palliative care agenda. So really bringing into play the social determinants of health. Could we go on to the next slide? So a good example, an international example, was from Singapore, where the Singapore Health Board wanted to reduce smoking rates within its youth, and they recognised that the top-down approach to offer education to at-risk youth would likely fall on deaf ears. So they focused a study on Singapore boys and girls homes, where the rates of smoking were significantly high, and they leveraged relatable topics into the curriculum. So through education and activities which the youth were engaged in, such as futsal, and they wanted to show how smoking affected stamina. And in 6 months, they found that the smoking, so 6 months of the intervention, they found that smoking within the study cohort fell from 40% to 10%. And meeting the participants' social needs was important for attendance. So, for example, belonging to the group of futsal players, and also in terms of it sort of looking good and being important amongst peers. We move on to the next slide. So how to establish a framework for an effective coalition? There are a number of facets. So defining a common language and shared goals is obviously very important, and establishing trust is also key. It's also important to recognize and leverage unique capabilities of all the partners that are involved, and to keep it moving forward and progressing. It's important to find a champion to progress the work. Setting clear goals is key, and to demonstrate how it will benefit each player that's involved, and to establish trust and secure lines of communication to enable data sharing across all major stakeholders. And also to assign a key executive to the central hub of activity to drive that work forward continuously. So, could we move to the next slide? An important example here is housing. So in England, the housing and health system in Wakefield recognised that housing could play a role in alleviating health system issues and in reducing costs. And it focused on Wakefield Housing District, which was known for its poor health. Specifically, 70% of the population carrying excess weight, and also having high rates of hospitalisation. The coalition signed a vision statement and worked together to prevent common tenant challenges. And a key intervention outcome was that 7% of calls for tenant falls required an ambulance post-intervention, saving an estimated £400,000 a year. Could we move to the next slide? So how is data and analytics important, and how can this guide the plan? So using predictive analytics is important in finding appropriate targets, filling data gaps with non-traditional sources such as consumer marketing, wearable devices that collect data, and relevant surveys, sleep studies, for example, and exercise adherence. And also expanding the categories of data collected. So being opportunistic about collecting richer data and taking advantage of system updates to insert new fields for data collection and collation. And also to simulate types of interventions and the impacts that they may have within systems. So using individualized data to predict health futures, as well as responses to potential interventions, is very important. If we could move on to the next slide. So in the USA, we have a particular case study that demonstrated the impact of Meals on Wheels on local healthcare costs and outcomes. And the program recognized that beyond the meal there was value, and they wanted to quantify this particular value. And they measured reductions in chronic conditions and improvements in quality of life across the virtual population. And one of the findings was that clients suffered an estimated 24 fewer heart attacks and 12 fewer congestive heart failure hospitalizations, and also 10 fewer strokes post-intervention. On to the next slide. In terms of working with the community and engaging with the community, it's important to ground programs in the reality of how people actually live and work. This includes learning from frontline workers and building trust, and being mindful of cultural and geographic disparities. And we'll come on to an example from India, which is really key and insightful in this regard. And also leveraging technology to unlock new possibilities is important, and thinking beyond the traditional systems of delivery that are in place. So it's key to gather information from local health workers to better understand the market and nuances and patient preferences, which is also extremely important, and then to tailor the approach to each market to earn the trust of patients and communities. It's important also to think about those that are difficult to reach, so to reach within rural and undeserved communities remotely, to provide new access to care. And apps have been very important in delivering this, especially during this COVID period. And also to expand access points to places that people frequent, such as grocery stores and retail health centres. And we have examples of Amazon, for example, in the real world, and other delivery methods that utilise these types of approaches and systems. If we could move on to the case study. So it's important that technology remains a critical and preferred channel. If we could just pop back to the previous slide. Technology is important in ensuring critical and preferred channels for consumers, but it must be accessible. So that the key thing is accessibility and simplicity, and also that there's a level of trust within, for example, apps and other technology-based systems of provision that are out there. So within our survey, we found that 56% of HRI consumers that responded indicated that they use or plan to use their smartphone, for example, to support their health. But not everyone has access to a chosen technology or are tech savvy enough to use that technology. And it's important to bear this in mind when creating these types of interventions or support to determine health outcomes. If we can move on to the case study. So an important example of this is a case study from India, which used accredited social health activists, so ASHA workers in India, to improve maternal and infant mortality rates. So communities chose accredited social health activists who belonged to or resided within those communities. And these chosen ones visited households within the communities, within the villages, to gauge the health of women and children. They were armed with technology to track medical records and to educate pregnant women on nutrition, hygiene, and vaccinations. And because they understood the local belief systems, they could effectively reverse misconceptions on unhealthy behaviours. They found that these interventions reduced infant mortality rates significantly. And also, they found that one technology in particular was credited with contributing to a reduction in 312 maternal and 149 in reduction of 312 maternal and 149,000 odd neonatal deaths, which is staggering. If we move on to the next slide. So in terms of reflecting and fine-tuning programs, it's important to reflect and also to define key measures, so financially and biological metrics, including the cost of savings, the cost benefit analyses, and from a biological metric perspective, individual level markers and population health metrics. And also to incorporate expectations from internal leadership into key performance metrics to ensure sustainability of programs in this regard. We can move on to the next slide. So again, an important case study here is from Australia, where the mission was to maximise the impact of coalition to reduce diabetes in Western Sydney, where the local health network created alliances with a framework of primary and secondary care prevention actions through a net framework of primary and secondary care prevention actions. And the alliance set measurable goals, such as reducing population weight, looking at HbA1c levels and prevalence over a 5-year period. And in terms of the framework and developing and refining the framework, they created an annual year-end review and report and a further plan for the year ahead to ensure sustainability of the programme, which helped refine a reflective approach, refining the framework and also the investment that was placed within that framework. So, just as a summary, so can social determinants strengthen the pharma strategy under new pricing models? So, in our HRI survey of biopharma executives in 2019, we looked towards sort of future pricing models, and half of the biopharma executives that we surveyed said that traditional drug pricing practices were unsustainable, and almost 90% of the executives that we surveyed said that healthcare systems would be challenged to afford the next wave of innovative medicines unless there were fundamental changes to how drug evaluation and payment models were placed within healthcare systems. So it's important from a drug company perspective, when entering into healthcare outcome-based contracts, that we should be thinking beyond the traditional patient support models and finding ways to really improve the social determinants affecting patient outcomes. Shane, back over to you.
Okay, thanks. I think we're just waiting now for the rest of the panel to join.
Good Morning, everybody. This is Jean Delaney here from PwC Ireland. I'm delighted to be here this morning. And we're going to spend the next little while talking to Nancy Moyes a little bit more about what they found in the study. I'm really pleased that Shane is with us from Ireland to add some Irish thoughts in it. And I'm even more delighted that Liam Cullen has joined us as well, given his policy role within GSK gives us an even wider global reach. But we might begin first of all with a quick look at what came out of the poll. I'm just going to click to now, I think. So it turns out, so what percentage of people's health is clinical care attributed to? 74% of you guessed 20% and full marks for paying attention. 60%, 26% thought it was that, and nobody thought 80% could get cured by treatment. So well done.
Isn't that such a... Jean, I was just going to say that statistic isn't. I don't know if that's a known statistic for everyone, but it's always brilliant to just think about that in this context, isn't it? So we spend so much time in health systems focused on treatment and cure, but only 20% of the, on average, of a person's health is determined by that clinical care, and 40% is socioeconomic factors, isn't it? And 30% own health behaviours.
Yeah, you're dead right, Nancy. And it did come back down to what we were always told: money cannot actually buy you anything. You can't buy your way out of it, or maybe more precisely, you need to start buying your way out of it much earlier in your life, in your environment, and in how you turn about your health, what you do about your own health. And I think it really does focus on that message, all right. And moving on to the next poll, when we look then at what people thought in their own lifestyles and what was affecting them. I thought this was a fascinating answer. 35, and our people have guessed 35% have gone for not getting enough sleep. With the other one, lack of time to become healthier be the other major contributor here of 45%. Now, that's not a million miles off what we saw in the results coming out of the Health Institute survey. I think slightly flipped, with sleep being a huge issue, about getting relaxed enough to get sleep, having enough time to have sleep, and getting the right quality of sleep. It's definitely preying on everybody's minds. And it's interesting that that's what our participants this morning also think might be going on. And then the final one, which we looked at, and this is about embracing technology. 89% of you have downloaded the COVID app. And we're going to come back to that later on when we talk about what makes technology attractive for people, and does it tie in with some of the themes that we've mentioned. But let's begin with just a little quick recap of what we said in the report. And the first thing was, where we're at the moment isn't sustainable. And we all know that. And you'll see if you read our report that your CEOs know that too, and know that in spades. We've just alluded to the fact that treatment isn't going to cure us of everything. It mightn't even stop us from getting worse. And if we want to make health outcomes a better reality for everybody and for health systems, it's down to us. And it's also down to the environment in which we operate, socioeconomic and physical. So that needs coordinated action across the healthcare spectrum. Now, this is the moment when I'm beginning to feel, oh my God, can we ever manage it? But the bit I found very reassuring from the report is it can be done. It's not necessarily easy. It takes time, but it can be done, and it can be done in a variety of ways and in lots of areas that we can see operate in Ireland and in our lives. So with that in mind, I'm going to put it to you, first of all, Nancy. Can we actually manage? We've talked about little bits and pieces in the report about case studies where people have focused on preventative. Can we really shift the dial to focus on preventative healthcare? And what does it take?
And I think we can, as we've seen from the detailed case studies in the report, that change is possible. It needs the right mindset and also the single vision of organisations coming together, because this isn't going to work with just single organisations working in silos separately. It needs organisations to come together, those with common objectives, building in those similar incentives and incentives for all partners involved, working together to address this. You might need that convener, as we've talked about, to bring all of these partners together, but having a clear common framework, single purpose objective that you're working to, and also importantly, tailoring that to your communities who you're trying to impact and reach out to, and those interventions being grounded in the reality of how people live and work. All of that is very important.
And if we talk about it, I mean, I think everybody can understand that and can feel that, Nancy. I mean, Moise, I know that you've spent some time working with people and are very conscious of where pharmacists, for example, have taken this, something that people we know, many of whom are on this call, we know and we see every day. Maybe you'd talk us through what we've seen and the dynamics around pharmacy intervention over the last while.
Yeah, so from a pharmacy perspective, it's also important that all stakeholders, relevant stakeholders, are engaged at all levels. So including healthcare professionals and community pharmacists, especially during sort of the COVID pandemic, we've seen the rise in importance of the community pharmacy, but also that's layered in with effective engagement from patients, from patient groups in terms of using that service, and also from a funding point of view. So, for example, how in the UK the Department of Health has supported and funding and it continues to fund that part of the primary care service in delivering its role, and also the preventative function within its role. So health screening, health promotion, health education are also extremely key. And we've also seen in the UK how the pharmacy workforce is and has been transformed, including the use of clinical pharmacists within sort of GP setting, but also cross sector within pharmacy. So we have an alignment and movement of secondary care pharmacists, clinical pharmacists, consultant pharmacists who are now actively out in the community setting, educating and involved in primary secondary prevention schemes.
But again, it comes back to the principles that Nancy talked about. You find people who are in the community and you look at how they can be used more effectively, and you get everybody around them, all the organisations around them, to buy into that concept and help make it real. But it can, again, as we said, it can be done. I mean, and if we move on then, thinking about financial sustainability, which, is a very unglamorous subject and everybody hates talking about it from a health perspective, but it's the reality. We need this to be sustainable. What evidence do we have, apart from anecdotal evidence, apart from our gut feeling, that this stuff actually works, that it helps make the system more sustainable? Nancy, have you any thoughts on that?
And I think this is an area where data and those metrics are really important. So each of the interventions, and you'll find that it really does vary. So some interventions, there's clear evidence and a return on investment, the benefits outlined. I think we need to be doing more of that. Financial sustainability is a key aim for all healthcare systems. And I think there are many factors that contribute to helping that sustainability. So we talked about that prevention, getting in right from the start to make those changes rather than focusing on the expensive curative treatment towards the latter end. But it's also other things like the investment in primary care, again, rather than acute care, genuine whole systems approach. So different organisations and companies coming together, pooling budgets, focusing on health outcomes, creating those new partnerships, managing unwarranted clinical variation, something around the processes that and the governance structure you've got in place to make sure things are efficient from an internal perspective, that grip and control that you have around those processes, and also adopting new digital technologies as well is going to be really key, and we can see a lot of those new technologies emerging now.
Yeah, and Liam, would you mind now if I jump to the pharma company perspective on this? And how do you see, or how have you seen pharma companies contribute to help make the system more financially sustainable? I mean, the cynics among us might go, well, sure, you just want people to spend more on your drugs. is that the world view, or is the CEO recognition that the system has to change really beginning to find its way into your day-to-day life in pharma?
Yeah, no, I think anybody involved in the industry from whatever side, Jean, would recognize there has been, over the last 10 years, especially through the years of austerity in Europe, a very sharp focus in relation to the expenditure on medicines, across all healthcare settings. And I think, there's no sign of that abating. I think the model, the business model is very much focused on, you conduct your R&D, you develop your medicine, you bring it to the market, you have a length of patent exclusivity, and then it's genericized and it is made available. And the cycle should allow for reinvestment in new innovation. And I think that's at the heart of our business model, and I think that needs to continue. I think the pressure from the payer side is to ensure that they're getting value for money, and I think from our side it's to be able to demonstrate the benefit of existing medicines and new medicines, and where we can use instruments, and I know we're going to touch on it in relation to real world evidence, and data to show how these new medicines work and the benefits. But I think at the heart of the question is the realization that these medicines should save healthcare systems investment in, whether it's hospitalizations or community care. It's up to us to demonstrate that, but also there needs to be a recognition of the fact that it is unrealistic to have a budgetary target that does not envisage increased expenditure on medicines into the future. And also, I would say, part of this frustration, certainly from an Irish point of view, but it's felt across European markets, is the kind of stop-start nature of the commitment to investment on the part of payers. That there are very few countries that we could point to that have kind of a coherent medicines policy. It's all looked at on kind of a budgetary cycle basis, and very difficult in that environment where you're talking about many years of R&D investment for a company to be able to plan from a commercial point of view, in terms of launch, in terms of return, and that has certainly given rise to concern locally and frustrations locally.
Yeah. Well, I'm going to pause for a little bit longer on this, because one of the questions that has come in has talked about, the quantum and the percentage that we spend on medicines. It's running at something like about 2.5 billion in Ireland, and it's about 15%. I'm not auditing for once. PwC is not auditing these numbers here, but I gather from Seb, our contributor here, that it's about 15% of the healthcare budget. So it's big. It's going to continue to attract attention, as you, Liam, rightly said, when we all believe that it's key to helping reduce the other acute costs. But convincing everybody else of that's going to be difficult. I mean, I know, Moise, you were saying in the UK that medicines portion has also been the focus of attention of, are we spending it in the right way, and how, it sometimes is creating some of the problems in the system. Maybe you'd talk us through that.
Yeah, absolutely. I think that figure is from my pre-research is about correct. So I think the spend is about 2.5 billion in Ireland, and I think the primary care spend within that is between 1.7 to 2 billion. And just a comparison, so within the UK, our spend is around the 20 billion pound mark. And what we're doing here in England is we've introduced a medicines value programme that's looking at improving patient outcomes and ensuring that the NHS obtains best value from medicine across health and social care. What's really important from our perspective is the data behind it and being able to track that data. So whereas in primary care we have access to fairly good quality prescription data, EPAC data, in secondary care it takes a bit of work to pull all of that information together through sort of complicated and that can be even more complex with high cost drugs. So the point I'm trying to make here is that with the data you can then start to look at what the spends are and then also what the outcomes are, what the clinical outcomes are to patients. So really driving it down to patient level data. And a really sort of important guiding statistic here, and an important statistic sort of within England is around concordance and compliance. So in terms of Liam's point, we're spending money. There's a lot of research that goes into producing medicines and bringing those medicines to market. But it's also important from a patient point of view that we have concordance and compliance, that those medicines are actually taken how they should be, which then includes a bit of education and ensuring that the right drugs are prescribed to the right patients at the right time. So in the UK, a quick stat: 5 to 8% of hospital admissions are due to medication, and 50% of people don't use their medication as intended. So clearly here, pharmacy and community pharmacy has a big part to play.
So Liam, I'm going to take you on now to real world experience, because I think it fits in nicely with our financial sustainability and the contribution that the pharma community or the pharma life sciences community could make about not only do we need to come up with the right drugs, we need to make sure they work and that they continue to work and that people know how to make them work and how to take them the right way. But looking at the work that got done around Salford, which I know GSK was heavily involved in, I mean, what real world evidence or that experience show you about the contribution that the pharma companies can make to helping drive that sustainability?
Well, just on the Salford lung study that you referred to, Jean, like, it's interesting in the context of the themes that Moise and Nancy pulled out earlier, insofar as, you know, it very much highlights the value of collaboration, the value of data, the value of tech. So, you know, the project was the first large-scale prospective real-world trial conducted across a patient population in Salford, Manchester. That, you know, the patient population was very big. It ranged between 3,500 to 5,000 people. It was kicked off in 2012 and looked at the treatment of asthma and COPD. And really, you know, it wasn't just the scale that was interesting, but it was the collaboration and the fact that it brought together, under the auspices of Northwest eHealth, you know, the Salford Royal NHS Trust, GSK. It brought together clinicians, data analysts, pharmacists, community GPs. So, you know, the network in itself was hugely important, and it generated, you know, a huge amount of data in terms of, Moise mentioned adherence, but just the way in which COPD and asthma patients, how they live their lives on a daily basis, how they engaged with healthcare services. And it allowed, really for the first time, that kind of ongoing monitoring of their conditions, and allowed for the collection of data, you know, and the creation of e-records. So all of that kind of digitization of data was hugely important. So, you know, the readout in terms of how NHS trusts use it, you know, from a procurement point of view, clinicians use it from kind of a health prescribing point of view, how patients reacted from adherence and the ongoing you know, check-ins from a clinical point of view. That was all hugely important, but it was kind of the collaborative nature of it, I think, that probably is now pointed to as its greatest success. And, you know, if you think about it, the traditional clinical trials, usually the point of data collection stops, you know, when the drug is approved by a regulatory authority. And there's very little evidence gathered afterwards. And, you know, Salford proved the value of doing that. So, you know, I think for us, there were huge learnings, huge benefits in it. And even if I think about a little bit of research that we were involved with the Asthma Society last year here in Ireland, like, it really highlighted the value of adherence, and the fact that, like, asthma hospitalizations by comparative standards are very high in Ireland. Visits to emergency department are very high in Ireland, and we kind of found through the research that, things like structured review, ongoing structured review could play, a huge part in avoiding some of that cost. So, we as an industry, I think, are very wary of the focus that, healthcare policymakers put on investment and the input cost. But the savings are real, and the potential for those savings through initiatives like this, could be very significant.
Yeah, and it's not to write off also the emotional cost that has been saved for everybody involved in the process, not least of which is the poor patient, but not having to go to hospital, not having to go to the doctor, all of those kinds of things. But I'm glad that you mentioned the asthma study in Ireland, because Shane, I want to talk a little bit about Ireland for a moment and the frameworks. When we've heard about Salford, we've heard about, it sounds almost like a textbook case. I'm sure it was harder in reality of the right people getting together, bought into the project and knowing what we were all trying to do. How does Ireland look if we're against that background? Have we got the frameworks, Shane?
So I think it varies in terms of where you're looking at. So if you look at sort of, and if we focus a bit on some of the more higher tech medicines, so if you think about the newer oncology treatments or cell and gene therapy and things like that, I would say that, we could do better in terms of how we think about it and how we engage on creating new opportunities for access for these products. So, really, when we talk about sort of frameworks, really what we mean is, that you're talking about something where there's transparency for people in the process. So understanding, who is involved, when will those type of reviews, or if reviews happen, when they'll happen, what is the timeline for them? So as Liam said, it allows sort of companies to sort of plan and think about, okay, in a year's time, will we be ready for launch, or will we have a decision 6 months out or 9 months out? So, there is a sort of, in terms of how you think about a framework, there is sort of transparency in the process. Also then in terms of, and again, it points here about, sort of the cross-functional sort of stakeholder involvement. So who will be involved in these type of products? Is it just a very sort of narrow sort of pharmacoeconomic determination, or is it sort of a broader view in terms of, what investment is required to bring these type of therapies to market? And also, what are the sort of broader sort of social sort of impacts for some of these products? And then really there is a part about sort of, having the expertise to actually be able to engage on these type of topics and kind of have a sort of a reasonable or back and forth discussion on that. So it's about the process, about single point of entry. It's about how, and the NHS have done very well here with NICE in terms of providing these types of frameworks. So if you were to think about it in that way, I would say that there is probably work to do, in that we do in Ireland talk about, supporting access, and in the recent budget, we have talked about, providing dedicated funds for high-tech medicines and other types of these products. And we do talk about it, but the actual reality on the ground is that it is proved difficult to sort of translate what people talk about into what the action that people are seeing on the ground. And I think part of that is that we don't have these type of, guiding or overarching frameworks that kind of provide this type of certainty. For everyone, right? For physicians that will know what products and how, when they're coming along the lines, and when they will transition from clinical trials through to sort of access and potential access, and then into the clinic, and also for patients, and obviously so for pharma companies and in their business planning. So I do feel that there is certainly on the higher end of things, in the more high tech medicines, there is work to be done in terms of operationalizing the sort of the very good intentions that people have talked about in the last few years. Okay.
We move on maybe a moment then to talk about, we've talked about frameworks, maybe we move on to data and technology just for a minute. I know I'm dealing with the science-based community here, and you're all data obsessives, and if the data's not right, why did we ever get out of bed? I deliberately exaggerate, but I'm a tax partner. I'm allowed for the moment. But seriously, looking at the data, what's useful? I mean, Liam, looking at a data company, there are those who argue that pharma companies are fundamentally these days data companies. How do you see the data environment about the order, what do you need? What can help you guys produce a financially sustainable product? Where are things at?
Yeah, so I think within our world, Jean, you hear a lot about new technology platforms and artificial intelligence and machine learning, and the potential that can bring. And, we've ambition that, roughly a figure is pointed to of 10% that represents, from kind of, phase one trial through to commercialization, 10% of assets make that journey. And we have said that, through new technology platforms, we would hope to be able to double that strike rate. So, you would have a 20% efficiency rate. But, the machine learning, the AI, all of that, they're the instruments, but you're very much depending on access to data and data banks, and the whole apparatus around functional genomics actually depends on that. So without that kind of rich reserve, whether it's access to NHS data banks, HSE, and there was quite a strong ambition in relation to Ireland for e-records and data. And just, I'd have a question as to where that is at on its journey. Those are the building blocks, as I said, that have to be in place. And it's only then that you can maximize your potential. But, I think there is that point that, and question about whether pharma companies, biotech companies, are transitioning into data. I think, the question is, do they have access to it, and who can they partner with to get access to the data? They don't necessarily want to be holding all of that data themselves. So, we've entered into collaborations with 23andMe, who has started out as kind of genealogy mapping and DNA mapping, and is transitioning into finding pathways for very precise and precision medicine and cohorts of patients within populations that we think our medicines will work on. So the data, the instruments are very important, but the data bank is the huge rich reserve basically that we're all struggling to get access to.
Okay. And can I compare and contrast the Irish versus the UK system? I mean, Shane, quick view on how our data banks and things like that. How's the environment in Ireland?
So if you're talking about what best practice looks in electronic health records and up-to-date data tracking and trends, you won't see that. Unfortunately, you won't see that in Ireland. I think everybody recognises that the data environment in Ireland is very challenging. And there are pockets. So again, if you look at where there is a sort of perhaps a statutory or agency element, so if you look at sort of haemophilia, maybe in cancer control in certain areas, or in sort of rare diseases, you may have sort of patient registries or statutory registries that track data, but linking that to sort of unique patient identifiers and linking that to their whole medical history and all of their visits, and that type of that type of data infrastructure that really allows you to look at things in total. We wouldn't be there in terms of, and we would be sort of lagging a lot there. So what you would say in Ireland is, if you're interested in rare diseases, you can probably get a decent understanding of what's happening at a cohort level and potentially a patient level. But for a lot of the rest, it's definitely a lagging sort of snapshot view rather than a sort of longitudinal view in terms of the data. So you can say a year ago, these number of patients were being treated with this or that, or were suffering from this. But in terms of saying, okay, now, and those patients, how they progressed over that time. So if you were to look at it from a national view, it would be very hard to make those type of discussions, and again, very difficult to sort of drill down into individual treatments or therapies. So I do believe there's work to be done.
Yeah, it's a view echoed by one of our questioners here as well, who feels that Ireland is falling behind other countries. I mean, Nancy, how do you feel the whole electronic data environment is happening in the UK and anywhere else that we see globally? Who's looking good in this area?
I think in terms of data around population health management, previously I would say, we would look abroad for those case studies and approaches and methodologies and tools. But actually in the UK, increasingly over the years, we have seen a lot more focus on population health management. We've had national programmes which have, at that national scale, pushed for this as well. It's not perfect, but we can see improvements. There's a whole big issue that's been overcome, or needs to be considered around that information governance and the processes around that, protocols. But in terms of the tools, I would say there's lots of good processes, tools out there, and we can see those tools now being used to really be specific about certain geographies, boroughs, and populations as well. Yeah.
Okay, so the bad news is we are behind. The good news is, yet again, it can be done, but we're back down to will and organisation and deciding if it's a worthwhile investment.
And
getting that collective will organised.
Jean, as well, taking learnings for where it's been done and actually building that in. And actually, the topic of that social determinants, you can use some of those metrics to factor in when you're building what data and the capture that you require as well.
Right. Okay. Can we turn now a minute then? So if we manage to get the data organised, now let's talk about technology. And I mean, we are sitting in an environment. Look at us, for example, doing this. We would never have done it without COVID-19. We have 89% of our population on this morning have downloaded the COVID app. We might never have thought we got to that. And we've got 2 million people in the country here have already done that. So, we've had telemedicine, we've got to electronic prescriptions, which the population, our audience this morning will know, really was looking like it was very hard to do until turns out that you really, really had to do it overnight. So you had that impetus. We've made leaps here. How do we maintain the momentum? And if we've all bought into the idea things can get done, what's the right technology to spend time on? I mean, Moise, there's a range of things we could do technology. What makes a difference in the context of social economic factors changing people's behaviours?
So, I mean, in the UK, in England, for example, there's been an increased momentum behind digital innovations across the NHS, certainly in the last 3 to 5 years, longer still in terms of development pipeline. And it's interesting to know, for example, here at Digital Health London, the programme director is a former pharmacist. So pharmacists are quite keen and knowledgeable in terms of their input. So the main sort of areas of focus around preventative healthcare include diabetes as a prevention program, and there are a plethora of apps available which patients can use. And which can be endorsed or are being endorsed by health providers. So app-based technology is extremely important, and also in terms of education, for example, you mentioned sort of asthma treatments, tailors, they provide a good level of information, and not to reproduce what's already out there, but provide it in an easily digestible format for the average person to understand and utilize. And also we have technology, so again, app-based and similar sort of online systems. But the 111 system is utilized in England. So 111 system is bringing an ambulance, and they're looking at increased technologies it can reduce the pressure on the ambulance service, but also provide an effective alternative substitute in terms of information, but also access to their call centres and their staff and services.
Okay, good to know. I mean, Shane, I know you have some strong views on where pharma companies should spend their money on technology. You might like to share them now.
It's probably from about a poor experience, but I think with technology, right, it's important to view it as a tool, right, and it's a tool to achieve something, and that target that you would achieve should be obviously should be measurable and achievable, and so you hear there are probably two things. One is when I personally have been involved with companies who spend a lot of time and effort in trying to improve the technologies in, say, their treatments. So, say, Bluetooth connected auto injectors to improve, adherence in diabetes, which is a very noble game. But then it runs into sort of problems in terms of if you have a payer that is only interested in cost containment and won't necessarily see the value in sort of improving adherence. And sort of a second example, which is probably more relatable, is when we talk about sort of apps. So there's apps on your phone and using AI. There's a lot of talk about this, and people are like, can't we just make an app for this? Can't we just do that? And really, the question that we would ask is, what do you intend to use this for? If it's for sort of to educate your patients in terms of what the product is or what your medicine is, how to take and how to use it, it's probably better that you spend that money making sure that your Wikipedia page or your WebMD page is up to date and clearly readable. And that, because this is where people go for information. So it's, you may create a very nice app and spend a lot of money on it, and it's downloaded by like 50 people, whereas you have like 50 million people going to the Wikipedia page for your product and reading what, some probably reasonably talented or gifted amateurs have put together based on information around that. So it's a bit about thinking in terms of what's the best actual approach that in using technology.
Okay, Liam, I saw you nodding vigorously there at one stage.
Well, no, just Shane's last point there, Jean, in terms of I think there was a phase companies went through across all industries a few years ago where everybody had to have an app. And I saw some data from IQVIA that said, I think, and this is going back a couple of years ago, that there was something like 7,000 healthcare apps downloadable on iTunes. And yet, I think there was only a handful that people actually used on any kind of a regular basis. So I think, it is very much to focus in on what works, what's usable, and not just having something for the sake of saying you have an app.
Yeah, I think that's true. Okay. We're coming close to the end now, and I think we have to talk on vaccination, which is one of our readers has said, will COVID-19 force a focus on preventative healthcare? What better introduction to the concept of vaccination? Now, I know, again, I am a complete vaccination fan. I am utterly bought into, it's the second best thing that ever happened to healthcare after clean water. So you've got me. I think you've got a lot of the population thinking about vaccination in a way that maybe they haven't with COVID-19. And GSK, as our vaccine person here, Liam, I mean, where do you see vaccination going? Where is it at the moment? Where do you see vaccination going in this whole conversation about preventative healthcare?
So certainly in the context of preventative healthcare, we would see vaccination as a huge tool for public policy makers, throughout the world. And, as you pointed to, the benefits are well known. But yet I saw statistics recently that said from an investment point of view that only on average 0.3% of health spending is actually dedicated to vaccination. So, in terms of reward on investment or return on investment, it is uncontested in terms of the benefits. And I think a couple of things, I'll come on to COVID in a second, but taking a step back in terms of the role that vaccination has to play in public health policy, I think there is, has always been, certainly in modern history, a tremendous focus on pediatric vaccination and the benefit of that. And we've seen, the eradication of smallpox and polio, and measles being controlled by and large throughout the world. I think there are tremendous opportunities for lifelong vaccination, and that's something that we've only seen the potential around kind of in more recent years. And, if you think about HPV, if you think about shingles, if you think about flu, those offer, tremendous opportunities. And, some of the research being carried out by people like Kingston Mills and Luke O'Neill and Trinity in the School of Immunology kind of point to the potential of linking vaccination into kind of tying it up with environmental behaviors almost, and looking at things like rheumatoid arthritis. So the potential is tremendous. I think what we would like to see is an ongoing commitment on the part of governments to recognizing the value of vaccination close to home in Ireland, I think there has been a very good commitment. I think the ongoing and future commitment is something we would like to see. I think, on the preventative piece and the pandemic, we see very clear evidence of the challenges that comorbidities present for COVID, and obesity is, a very worrying trend in terms of health outcomes. So, there is a tremendous value in keeping your population, your labor force healthy, and God willing, we won't be experiencing a pandemic scenario on an ongoing basis or any time in the near future. But, a key determinant of outcomes is how healthy your population is going into a scenario like that, and vaccination, even rudimentary things like flu have a tremendous role to play in that. So, obviously, we see tremendous value in it. I know IFA have campaigned on that front very recently, and it's the ongoing commitment we would like to see.
Okay. Well, I think it'll be very interesting to see how we get if and when we get a vaccine for COVID, or many vaccines for COVID over the next little while, how all of that plays out and the degree of buy-in from the population to really going for it and trying for it. And it'll be a great experiment. Nancy, before we finish off, any closing remarks, anything that you'd like people to take away from this and to focus on? What's the positives here? What can we do to make a difference?
I think the positive is we can make a difference, as we've heard, and all the examples that we've talked about and the consideration. So I think that's the positive, is we can do this, but it does require thinking, more focus beyond the traditional ways of doing things. So if that means challenging each other, challenging, our partners that we work with, building that collective will and putting our people, citizens at the centre of making that change. I think it is, but it needs action and it needs focus.
That's great. Listen, thank you very much. Can I thank you all for that? That was a great discussion. And with that, may I hand back over to Oliver.
Yes, indeed. Thank you, Jean. And thank you very much, colleagues from PwC and indeed Liam from GSK. Look, from the pharmaceutical, that was extremely stimulating. I just wish I'd been on the panel myself. So can I summarize? First, I do think that, the avoidance of cost will be focused very much on chronic diseases that are, growing far too fast and causing a lot of cost. Chronic diseases that are preventable by focusing on the social determinants, and that then frees up available, resources to spend appropriately on the innovative high-tech developments which we want to see for curative purposes, for treatments, for those conditions, for all sorts of conditions, but especially for those that are unavoidable. And so this is where we see the role of they have really high-end cell and gene therapies. It is entirely appropriate that states and governments should seek to fund those and seek to and pay for them. But they can do so sustainably when the chronic disease burden is reduced or minimized through social determinants to addressing these things which you've focused on today. And if I were to say there were two things that pharmaceutical people working in our industry in Ireland would love to see, one would be, the predictable and well-organised reimbursement system, of course, and there have been good steps towards that in this year's budget. But the second thing I think I've heard so many times from all of us is that we would love to see Ireland adopt and have a really well-structured data and health management resources to match the scale of international investment in the country from our industry, but also from other life sciences industries and from the tech industry, because it seems like such a great opportunity. And I think at a personal level, all of us would love to see that scale of investment matched by a scale of adoption of innovative practices, many of which would address the social determinants of health. And I've heard that expressed so many times by individuals, by companies in our association and in the life sciences sector. So it's great to be stimulated to think of that again and to see what we might be able to do to advance that cause. and we'll certainly have a good few takeaways from today's discussion. So thank you again to PwC. Thank you again to our sponsor, Unifar. Thank you for all of you who took part or listened and put questions in this discussion this morning. And we look forward to hearing, seeing, being with you again for the final of our Digital Thinking series coming up in a few short days. Thank you all again. And with that, I'll say goodbye.
Thank you.
Thank you.